Of course, there's always lots of terms in this textbook that you need to be aware of. Acute pain, of course, neuropathic pain. Neuropathic is important to remember because many of our drugs work in the peripheral nervous system or in the central nervous system, so it's important to know what does neuropathic pain mean. Basically, this is where the central or peripheral nervous system is not working correctly, okay? Nociceptive pain, of course, is from mechanical or toxins or heat. It can be somatic, right? Or it can be visceral. Generally, the somatic is, for instance, visceral, for instance, is if there's a nerve that's being stretched on an organ, that would be more of a nociceptive pain. Persistent pain is generally chronic pain that's been present for 3 months or longer. So there's various terms that you might see, and so be sure you're aware of these terms. So the first statement there, comfort is a relative term, obviously makes sense because to some people it can mean that there's enough pain control to help them for a couple of hours so they can get some rest. Other people may view comfort as freedom from, say, physical or emotional or mental stress. And others think about luxurious, pampered living as what we call comfort. However, we do know that the term comfort means to relieve from distress, helps to lessen anxiety or misery, freedom from pain as well, and worry, and to inspire someone or to help them be calm and worry-free. However, we think about comfort and pain when we talk about holistic nursing. That means that we can think of it as a physical problem. It could be emotional, social, and even a spiritual well-being or peace. And so comfort is, it means different things for many people. Unfortunately, we do know also that comfort is a state of mind and that it's taken for granted until something happens, like somebody gets injured or burned or having some kind of emotional breakdown. Then the meaning of comfort definitely changes. And so a lot of times we don't think about our comfort until something really hits us, right? And so with aging, the things that can cause discomfort increases. Some of those factors will increase, and it will threaten our patients. So comfort is something to be well aware of. So that's just a term. So pain, though, remember that pain is the fifth vital sign, and it is very important as an indicator to the individual's overall health, is what is their pain. So the greatest threat to comfort we know about is pain. So there is a definition. I'll read the definition here for you. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, implying that there had to be objective cause for the pain. Okay. We do know that pain now is subjective, and it depends on the person's response or their own perception of pain. What does pain means to the patient? That's what we have to remember. So let's talk a little bit more about the older adult. A couple of things. Older adults may underreport pain. They don't want to be viewed as complainers. Maybe they don't have the money to seek treatment. Maybe they have lack of funding. Or they, unfortunately, erroneously think that pain is a normal part of aging. So for some statistics for you, the National Center for Health Statistics, 1 in 4 adults suffers a day-long bout of pain in the past month. 1 in 4 has pain during the day, a day long, the entire day. 3/5 of adults that are aged 65 years or older said they experienced pain that lasted for a year or more. Wow, that's interesting. Low back pain is the most common complaint that we see among our older population, along with, say, migraines and severe headaches. Joint pain, aching, or stiffness is also something. And the knee is the joint that causes the most pain, according to the National Center for Health Statistics. And recently, knee replacement surgeries for patients over the age of 65 has skyrocketed. The new way of doing a knee replacement, the more modern techniques, and people over the age of 65, many of them are still living life that they want to be able to get around, and so many of them are seeking now to have some knee joints replaced. Severe joint pain does increase with age, and women tend to report severe joint pain much more often than men. So as nurses, we need to be aware of how's the pain affecting our patient, number one. The various types of pain. What are the effects if the pain is unrelieved for our patient? What is the cultural impact of pain is very important to remember. And what are some patient or client specific actions that we can do for our patients who have pain, whether it's non-pharmacological, pharmacological, or even complementary, such as relaxation techniques. So we do know that pain is a severe problem in our older population. Okay. So there are types of pain. This is important to review because this is physiology now. Basically, we have two types of pain, nociceptive and neuropathic. So the nociceptives, or the pain receivers or receptors, they're free sensory nerve endings, and they are found, of course, throughout the body. Temperature, extremes of temperature can cause pain. Acids, chemicals, histamine, all of those things can cause pain, and this is for nociceptive pain. And of course, physical pain could be like pressure, pain of pressure. Notice that for the somatic and the visceral, there's a difference between the two. So somatic is usually from the skin. It's usually an inflammatory process that's coming from tissue damage. It can be a bone or muscle pain, of course, and it is conducted by your sensory fibers. That's the somatic nociceptive type of pain. Visceral pain is more disorders that cause like generalized pain, or what we call referred pain, like deep and aching, and usually originates in the organs. The sympathetic nerve fibers are the ones that conduct that pain sensation, and visceral pain can be acute or chronic. Right. But what about neuropathic pain? This is the second type of the pathophysiological mechanism. So neuropathic pain is more sharp, stabbing, tingling, burning. When it starts, it's usually a high intensity type of pain. It could be peripherally or centrally generated. It could be periphery or centrally generated. The patients can sometimes describe it as burning, numbness, shooting, stabbing, prickly sensations, electrical, and even tingling. So that's the difference between neuropathic and nociceptive pain. So be sure you know this pathophysiological and the physiological mechanisms of pain. We won't go into all the details about the gate theory and all that. That's not what we're doing in this class, but just a reminder about these types of pain, because many of our medications that we give our patients may only work in the somatic or visceral classifications of nociceptive pain. Okay. All right, so this is a really good little way of looking at pain. The perception of pain is different for all patients. It's very unique specifically to that patient. And the perception of the painful stimulus begins in the brain. So it's in the brain, and it can change based on if something else is trying to interfere or competing stimuli. So for instance, the TENS unit, the TENS unit, can cause some stimulation and take the mind off some other type of pain, or maybe the sensations in the brain, the medications, for instance, can dull the sensation of pain in the brain. So the pain experience really is different for every one of our patients. So a large component of suffering includes physical pain, as you can see. It can be emotional, psychosocial, and obviously spiritual. So in order to us to care for patients who have pain, we have to look at the big picture. We don't just look at the physical problem of pain. We look at how is it affecting them emotionally, spiritually, and psychosocially. Just remember that as nurses, we are not only looking at the physical aspects, but all of these other pieces as well. And all of those together really give us an understanding of the patient's experience of pain. So we really are holistic when it comes to pain control. Successful pain management is not just one thing that we do. It's not just in the hospital we give a pain medication. There's much more that we can do. Lots of other, maybe some other activities or some repositioning of the patient or other many things, or talking with the patient, letting them talk. That can also help manage that pain that they're perceiving. So what are the effects of unrelieved pain? Well, obviously, patient's not going to get up out of the bed, or at home, they're not going to get out of the chair because they have limited mobility because of the pain. They're not going to dress themselves because they have pain in their hands. So it can actually cause inability to move, those fine motor movements, or even the gross motor movements. Pressure ulcers or pressure injuries can occur. Patients who has pain, they're not going to be able to deep breathe and do that nice coughing that we'd like them to do, so they wind up with pneumonia and other respiratory problems. Of course, unrelieved pain, because we become immobile, I don't want to move a lot, is going to increase the risk of constipation in our older adults. They're not going to want to eat, obviously. After a while, pain can cause depression and hopelessness, and we've already talked about depression and what happens in that situation. And of course, spiritually, it can be a problem with them in their eternal and their spiritual realm. So let's look at a question. Which of these describe somatic pain? Which one of these is somatic pain? Yeah, well, is that what you said? Well localized throbbing or aching?
Yes.
Yes, that is what we call somatic pain. Yes. because remember, this type of pain is very characteristic of pain in the bone or soft tissue, well localized, and it's generally described as throbbing or aching. So this is known as somatic pain. But of course, we have to assess pain. So how are we going to assess pain? There's multiple ways. We're going to ask some questions for a pain assessment. Open-ended questions is always better, as you know, through your therapeutic communication, not just a yes or no question. Of course, we're going to do that detailed pain history. Our physical exam, we're definitely going to be doing some ongoing assessment. And of course, the cognitive impairment of your patient. So how is that affecting our patient? I'm sure you remember the different ways that we assess pain, the description, location, frequency, the timing, PQRST, I think y'all remember that. What helps it, what causes it to occur in the first place, does it radiate to other parts of the body, how strong is that pain? We also use different types of scales, which we're going to be looking at just a moment or two. Looking at pictures for the pain to be rated, verbal rating scales, the patient will tell you verbally how they're feeling. And of course, there are some others known as the FLAC and the pain AD, and we'll look at some of these in just a moment. So there's many, many ways to assess pain. So we are going to watch this pain assessment video because it's specifically designed for the older adult. You're used to doing pain assessments all the time, but now we're really going to be focusing on the older adult. But some things, it's important to remember the signs that would indicate an older person with cognitive impairments is in pain. And I believe we mentioned it. I think, Melissa, I believe you made a couple of comments about your patient that you had with the skin problem. Was it crying or making any unusual grimacing things? So that's why I asked you about the pain this morning. So thank you for that sample. That was great. Vital signs changing, perspiration. If they can walk, are they pacing a lot? Are they wandering around? Are they hitting, banging objects? And remember, these are cognitive patients who have cognitive impairments. Are they splinting? Are they agitated? Sleeping? What's their appetite? How's that going along with the pain? Is there a problem? And their decreased socialization. So important to know the signs that could indicate pain in someone who is cognitively impaired. All right. So let's go ahead and look at this pain assessment together. Let's see, I think I already have it running, so I'm going to pull it over here for us. All right, it is also from the Hartford Geriatric. So this is a really, really good pain assessment. Please take notes on this one as well. And I guess I need to make sure that I have the sound on. So what I will do is stop sharing and then share again to make sure that's, yeah, I have to put that sound on. All right, everybody ready? Sit back and relax. This is one of these two videos that I showed you are very important ones for nurses. All right, so let's go ahead and watch it. This is a long video, but I want to watch all of it with you, and then we're going to talk about pain assessment. This is such an important piece of nursing practice. That's why we're going to watch it together.
This program demonstrates how nurses and others can assess pain in older adults at all levels of cognitive status and ability using 4 different tools: the FACES pain scale, the numeric rating scale, the verbal descriptor scale, and the pain add.
Pain is not a normal part of the aging process. Certainly, it's associated with things like osteoarthritis, which is, prevalent. Certainly, pretty high prevalency rates of osteoarthritis in older adults that can cause pain, but it's not a normal part of aging. There needs to be a plan in place, and it needs to be discussed with that patient as to what they want to do, because patients are very reluctant to think about taking a narcotic or adding another pill to their regime when they're already taking a large number of medications. Mrs. Kelleher is a 77-year-old female who's been a resident here at Village Nursing Home for about a month. And she came in with a primary diagnosis of a knee injury. I guess she did have a fall. She did not sustain any fractures, although she has history of knee replacement and hip replacements. And she came here with some issues with pain. She's also a diabetic, so she has some neuropathy that we're aware of. When she first came in, we had ordered Percocet, 2 tablets for her to get that 30 minutes before therapy, really to facilitate that and hopefully get her moving some more. And she also has an order for Percocet PRN as needed.
Could you tell me about your pain today?
My pain this morning when I got up, it was at least a 5. A 5.
How's your pain now?
My pain is it's good and it's not bad. It's not good, not bad, but it's good because the nurse had given me my medicine.
Okay.
She says I should take it now because I'll be going for therapy later.
Okay.
I'll have less pain when I go down.
Okay, I'm a little concerned today because earlier today you were rated on the pain scale as a 2.
Yeah.
And you're saying 5.
Yeah.
Is there something we could do to help alleviate your pain?
No, I don't want to take any more medicine. I don't want to take any more, only what I'm taking.
Okay. I'm going to use another scale today just to see how you are with pain. If I ask you a question, could you answer it for me?
I hope so.
Okay, could you please describe your pain from no pain, mild pain, moderate pain, severe pain, or pain as bad as it could be?
Moderate.
Moderate pain?
Yeah.
Could you tell me some things that you've noticed about Miss Keller that helps her with her pain?
Sometimes I ask her if she want to lay down in the bed, and she say yes, and I put the pillow under her leg to make her comfortable, and she feel better.
It seems if I walk in the hallway, with the walker, with that rotor thing, it eases the pain. When I walk, like I'm exercising.
Yeah.
That's nice.
I'm exercising.
So the medication we give you before therapy, do you think it works for you?
Oh, it does. It works for me.
It helps you with the pain, so you could...
Yeah, but I don't want to take a lot of medication. My kids don't like me to take a lot of narcotic medicine.
The Try This for pain assessment in older adults focuses on 3 screening tools that we use for self-report of patients' pain. So the first tool is the numeric rating scale, which is a scale that asks patients to rate their pain on a scale of 0 to 10, 0 being no pain, and 10 being the worst pain that they've ever had. And that's a very common scale that's used across settings in patients of all ages. The second scale is the verbal descriptor scale, and that asks patients to describe their pain based on a qualitative description. So you ask patients to rate their pain, whether it is mild, whether it's moderate, severe, or the worst pain that it could be. And then what you can do is you quantify their responses. So you can still use a 0 to 10 scale when you're following the screening and or the evaluation of any intervention. The third scale is the revised FACES pain scale. And with this scale, the nurse or other health professional that's using the scale has a card with a visual image of faces of varying degrees of grimaces. So it is from 0 to 10, 0 being a happy face and 10 being a very, strong grimace. And you ask patients to select the face that best describes what they're feeling. Patients who report pain levels of 7 or higher, you're certainly very concerned about. And at times when you begin to manage somebody who has pretty significant pain, you can actually have protocols that would provide an intervention and then another intervention if the pain remained at a level of 7.
My name is Israel Cassiano. I'll be your nurse today. This is Michelle Maxwell. She's the new employee at Village Nursing Home. How do you feel today? I've noticed you're a little uncomfortable. Are you in pain?
Yeah.
Okay. I've noticed the nurses have been using the face scale. If I show you the scale, could you show me on the scale what your pain is?
I guess this.
Okay, so you're saying your pain is an 8. Is there anything I could do for you at this present moment to help you with your pain?
Just get my medication quickly, please.
Okay, let me go get your medication. I'll be back in a few minutes, okay? Relax.
Thank you.
So you might have an order that would say to medicate the patient with 1 Percocet, and then if the pain is not relieved within 30 minutes or the pain did not go below a 7 within 30 minutes to an hour, that you would give an additional Percocet. But pain upwards of 7, we are very concerned about and would want an immediate intervention for that patient.
Well, thank you.
Miss Verbe, could you tell me on the face scale how your pain is now?
I'm about here.
So you're getting some relief from the pain medication?
Definitely, yes.
Is there anything else we could do for you?
I don't think so.
The use of these 3 self-reporting tools can become confusing at times for some clinicians who may for some reason believe that the patient is either over-reporting or under-reporting their pain. So it is important to do a more in-depth assessment by the nurse to have a discussion with the patient. For example, if the nurse believes that the patient is under-reporting their pain. And we see that sometimes with patients who have depression and for a variety of reasons. So if the nurse believes, based on other assessments, such as a depression assessment or a behavior assessment, that the patient appears to be experiencing more pain than they're reporting, then that would require the nurse to dig deeper and to talk to that patient. Very often, we do see that nurses believe that patients are over-reporting their pain. And that is something that we really caution nurses about because we really do not have a mechanism to identify that somebody might be over-reporting their pain. The challenges in using any self-report pain assessment tool is having clinicians consistently use a standardized approach to their assessments. So you want to try to embed the screening and the assessment into currently existing policies and procedures, into standardized tools that the nurses are using. So if nurses are using standardized monthly progress notes or admission forms, you would want to be sure to include that. Because if it's not part of a routine and the process of what the nurse is doing, then you will have assessments and screenings fall off, and it won't become just a natural part or a 5th vital sign, as we say. One of the things that I read in the chart indicated that Mrs. Kelleher might have some fears about taking narcotics, some fears of addiction, and she mentioned something about her family, and I haven't had any conversations with her about that, and I wonder if anybody else did.
Well, I did. In working with the patient and the family, I mean, they were starting to tell me that they were concerned about addiction to the narcotics and possibly some side effects. And it really is a concern of hers. So they wanted to know maybe if we could really focus more on the alternatives as opposed to really just looking at the pharmacological aspects at this point.
And, I understand that that's a huge concern often with folks and taking narcotics. So it's important for us to make sure that they have the appropriate education, that the risk of her becoming addicted is really extremely minimal. And, especially with her neuropathies, I think it's really important that we continue with the Neurontin that she's on. And maybe we can add some acetaminophen. And if we use that in, timing that with the Percocet, I think that when she goes home, we have to think about what are some of the other interventions as well in terms of the medication. At this point, do you think that she's has some knowledge of the exercise program she's going home with, or where are you with that, Daryl?
Well, I would probably like to start implementing something down on the floor with the CNAs and stuff like that, that they can start an exercise program while she's in bed. That would decrease the edema a little bit. Maybe we can do some cold pack or ice and bring that into play on the knees if they're having a little bit more pain at the time, which could help. We could also work with maybe a TED stocking or a compression garment of some sort. Her socks that she's wearing right now, I don't think are compatible with the edema that she's having. So I think something on the TED stocking would be a better implement for her with the edema. We can also train her with a home exercise program. So when she is discharged, that she will have some sheets of paper to take home so that the family and all that can stay on top of that with her at home.
One of the other things that I'm thinking of is that I think we need to be discussing with her about a pain diary and trying to get her to keep a pain diary. And I know, Israel, you used 2 different scales with her. Did you feel comfortable that she was using the numeric rating scale appropriately? I know you had validated it by using the verbal descriptor scale, but do you think we should consistently continue to use the 0 to 10 with her?
Yes, I think it's consistent. I think she's able to let you know about her pain and describe her pain.
Do you think that that's something that she would want to do, to do the pain diary? Could we maybe think about working with her
Yes,
on that?
I could educate her about the pain diary so when she goes home, she can keep track of it for the doctor's records.
Right.
So he can know if the pain medication and the interventions are working with her.
Right. And I think it's important also to be able to document what the non-pharmacological interventions are, obviously for her sake, for the family's sake. But I also think that we have to be realistic that she is somebody that has had some pain prior to this, and that, she probably is going to go home with some Percocet. And maybe we could discuss the possibility of her being on a standing dose of acetaminophen and using the Percocet PRN. We should make sure that it's very clear on her discharge papers that she is somebody who has had pain, and talk about this a little bit, that she has been reluctant to take some pain medication.
If I can just add, I'll make sure that I speak with the home health agency and make sure that they're really aware about the compression stockings and her feelings about narcotic use and her reluctance sometimes to take the medications. I'll make sure they know specifically to work with her with those issues when she's transitioned to home.
That's great. And is her family coming in when she's being discharged, do you know?
Yes, they're coming in to drive her home.
Okay. So that might be something else that you mentioned to them, is that we've had these discussions with her and this is the plan moving forward, and just reiterate to them the very low risk of her becoming addicted and how important it is for her to continue to move around and, to manage her neuropathic pain as well. Anything else? No? Okay, thank you very much.
I think in terms of people with dementia, the recognition by nurses that they might be having a problem with pain is extremely underappreciated. And we're just beginning to understand some of the behaviors that might indicate pain. And so there's going to be a lag probably in nurses' understanding of that. But certainly more and more nurses, I believe, are associating some of these behaviors that we see with pain and trying to treat pain. On the other hand, I think they still have a bias about, so if you do see pain in people with dementia, what do you do about it? They are at a loss for what kinds of treatments you might think about doing and how to go about doing that. today we're going to be talking about an instrument to assess pain in people with dementia. And I'd like to introduce the people as a part of this program. On my far right, we have Yi Yan, who's a student, and Mary Miner, who is a hospice nurse, and Rebecca Scobie, who is also a student. So we're going to be talking today about the PAIN AD, which stands for Pain Assessment in Advanced Dementia. And Mary Miner uses this instrument in her clinical practice. So we're going to be looking at a few video clips of people with dementia and talk about the PAIN AD specifically and how we would use it to assess pain.
In the pain net scale, we have 5 behaviors that we assess the patient for. The first one is breathing independent of vocalization. So you might be looking for something like rapid breathing, people holding their breath, just any kind of different kind of breathing you want to really pay attention to when you're working with the patient. The next one would be negative vocalization. If someone were moaning or yelling out or crying or swearing or those kinds of things, those are all signs of that you would take note of. The next one would be facial expression. People that might be grimacing or scowling or any change in their face that would lead you to believe that something is distressful for them. It might be a look in their eyes. It might look fearful. Just anything out of being pleasant you would watch for. The next thing would be we watch for real closely is for body language. And I think you're probably all familiar with that. It can be, they could be very tense. They could be fidgeting in their chair if they're sitting up. Easily just looking away, and just those kinds of things that you would watch for with body language. And the last one is a little bit more difficult to assess, is the consolability. When these people are exhibiting behaviors that you think might be painful, can you console them? Can you distract them with you're comforting them, or are they totally inconsolable? And you probably have all seen that too, where someone is in so much pain that they just continue the behaviors of crying or whatever they're exhibiting. Continue the behaviors of crying or whatever they're exhibiting.
Mary, I wonder if you could say a little bit about how the instrument is actually scored, what the scale is for each of the items.
Well, each of the items, there's 5 items. So, and they're all scaled. Each one is scaled 0, 1, or 2. 0, of course, would be normal behaviors. And then the 1 and 2s are depending on how much of the behaviors are exhibited when you're working with the patient. The total score would add up to 10. Or so you have a score then from 0 to 10.
I think to set up the first one, Mary, do you want to, I think actually this gentleman has some score in each of the 5 areas, is that correct?
Yes.
So we'll play the tape and look at the tape and then talk about what we think we saw.
Sit up. Why sit you up, David? I think he's driving. I can tell him that.
Do you want to start, Yi, and tell us a little bit about what you saw in that video?
Using the tool, I assessed the patient's pain score as a 9.
Okay.
I think he is having a severe pain. I will go through all these categories, how I scored it. For the breathing, I think he had little short period of hyperventilation when they're moving him and when he's really growing. And for the negative vocalization, we all heard a loud crying when he's being moved. And the facial expression, I think he has this big grimacing on his face. And the body language, I can see him really being rigid, and he's kind of pushing back when the aide's trying to move him. And for consolidability, I hear the nurse say, it's okay, but he continued his crying. So that's how I scored it. I scored it as 9.
Okay, very good.
And I would agree with your assessment, E. I came up with an 8 because I gave the consolability a 1. That's often one that I fluctuate, and so sometimes in my head I'll go, oh, he's an 8/9, depending. And if you were actually there and had more time to work with him, he probably would be a 2 for the consolability. So, yeah, those are the harder to overall are a little bit harder to assess. So you have to just pay a little more attention, and it might even necessitate further assessment on that. Either, for me, it's often when I'll say to a staff person, when you're going to change them or get them up again, I'd like to be with you so I can reassess. So it's not often that I do it on one assessment. Sometimes I have to go a little further, or I might just assess them myself, turn them, or try to maybe figure out if there's a way he can indicate to me where his pain is by doing a gentle hands-on assessment. And I might even say, like say palpate his abdomen or move his arms and say, is this hurting? And even though he doesn't answer, you might be able to tell by his facial expression, oh yeah, this is a source of pain.
How important is it to do this assessment during movement in your experience?
Well, I think it's very important. In hospice, our number one goal is that the patient be comfortable for his quality of life. And I think someone that has to lay perfectly still in bed, that's not really comfortable. And so I always move patients to see if they're comfortable when they're moving. We've all had pain where if we lay really still, we don't hurt. But if anybody moves us, it does hurt.
Okay, this is the second clip that we're going to assess for pain using the pain ad.
In this particular clip, watch his facial expression and his body language in particular.
Okay.
Put your shirt on. Mr. Watsky? Yeah, you have to let go. You have to let go. Thank you. Let go. You have to let go.
Okay, this time why don't we start with Rebecca? Do you want to say a little bit about what you saw on this tape, Rebecca?
Sure. Starting with breathing, I didn't notice he was breathing hard. It's a little bit difficult with a short clip, but I gave that a 0. For negative vocalization, I also was unable to hear him saying anything, so I gave that a 0 as well. And facial expression, he wasn't grimacing, but he did have almost a sad or fearful look, so I gave that a 1. And body language, I I think that I
Was
gave
that one harder?
a little bit. I gave him a 2 because he did seem to be pulling away when they were applying pressure to his arms trying to dress him.
Okay.
And as far as consolability, I'm still confused on that one. I'd say I'd give that a 0 as well.
Okay, good. Do you ever find that even though the total overall score on the pain ad is relatively low, maybe a 2 or 3, that because one particular indicator is very strong, that you might be more suspicious of pain and maybe actually treat the person?
Absolutely, absolutely. Yeah, that's very, very true. And I wonder if that isn't why in my mind I play around with some of the other indicators, because his body language was a definite 2, and in your head you're probably saying 2 plus plus,
Right.
and so which would warrant medication. And so sometimes you think, oh, a pain of a 2 or 3, we don't need to medicate. But in a situation like this, I would strongly consider starting some medication and then reassess. Do that and or reassess what you just saw even further.
I think one of the first things that I always look for, particularly in people in nursing homes, is how the care is given. And I think you'll notice that it wasn't the most gentle care in the world that we saw on this clip. So one of the first things I would always do is to examine our caregiving and how we're doing that, and try to figure out if there are more gentle ways, better ways we can give care that doesn't stimulate pain so much in people. So Mary, could you talk a little bit about how you would think about medication, any analgesic medication for this patient?
I would think about starting him on something routinely, and it would probably be a gentleman I don't know real well, and he's probably not been on, I'm guessing he's not on any routine pain medicine or even PRN medicine. So I would, in my brain, think about the World Health Organization analgesic ladder, where you start off with a mild analgesic like Tylenol. And Tylenol is fairly benign, so I probably would schedule that, like QID. And depending on his age and his condition, maybe start even with just the 650, and then you would be allowed to have the PRN dose. If you use the higher range, then you have to remember that there's a max on Tylenol. So I would start with that and then reassess, and then climb up that ladder as needed for his pain control.
So do all the people with dementia have the same pain behavior?
Well, I think as any of us exhibit our behavior in an individual way, that's also true with a dementia patient. And so this is a tool, and this is a guideline for me. And it wouldn't be the only thing that I would rely on to determine if someone is in pain. Of course, you would go to the chart and get the medical history. I talk to family to see what kind of behaviors they're familiar with. If there's no family, I talk with staff. And I try to get everybody's assessment of it, because oftentimes, not oftentimes, but once in a while, you'll get staff, particularly maybe the aides, that will say, well, they always act like that. And so that's, I try to listen to that, but not totally take that as the final answer, because maybe they always act like that because they're always in pain.
The PAIN ad stands for Pain Assessment in Advanced Dementia. The PAIN ad was developed specifically for clinical purposes, not for research purposes, and it contains many of the important indicators of pain. It's easy to use. Once you're skilled in using it, you can pretty much do an assessment in a minute or two. It's very important that you do the pain ad or use the pain ad as an assessment during caregiving, because as you're moving the body, you're likely to stimulate pain. So you want to observe care when it's being given, or give care yourself, and then observe the older adult while you're doing that. The pain ad should be done primarily on people with, well, on people with dementia for sure, but mostly people who have either lost entirely their verbal abilities or mostly lost them, where you can't understand what they're saying, or what they're saying doesn't really make sense to you. So in those instances, you would want to definitely use a pain AD, or the pain ad. It was developed for people with severe dementia who could not verbally express their pain. But I would say, however, in addition to using the pain ad, that I like to recommend that you always ask people if they're having pain, whether they can respond to you or not, because sometimes they'll just be in a good place and they're clear mentally and they can say yes or no, or they might be able to shake their head yes or shake their head no. So I always like to do that, to give people the opportunity to tell me if they're having pain, and then to use this in addition to that. The pain ad should be part of a much broader assessment. You don't want to rely on the pain ad all by itself. So you should be evaluating the person's history, their medical history, whether they have other health problems that would might precipitate pain. You need to talk to family members to see if they have a history of pain, how they handled their pain, how they responded to pain. You would also want to talk to different clinicians or caregivers who are taking care of the person, what kinds of things they observe in the person, and combine those evaluations with the pain ad. And if you do that, it's likely that you can increase your confidence in whether or not you think the person is actually experiencing pain. The pain ad can be done by many different professionals with a little bit of training, depending on who they are. I think nurses, other healthcare professionals such as physical therapists, recreational therapists, occupational therapists, certainly physicians, can teach themselves to use it. On the Try This page, there are instructions in how to use it, and there's actually, in addition to the tool itself, there are explanations for each of the indicators and at each of the severity levels. So a nurse could go to that, or a physician or other healthcare professionals could go to that and learn how to use it themselves. How frequently the pain assessment is done depends quite a bit on why it's being done. For example, if you have somebody who has a pretty high score on the pain ad and you're doing interventions with them to try to get the pain score lower, you would want to do a much more frequent assessment. You might want to do it every day or several times a day. If it's somebody who doesn't have pain, or they have very low pain rating on the pain ad, and their history doesn't suggest they would have any reason to have pain, you might want to do it very periodically, once a week or once a month, maybe even every 3 months. It just depends on your protocol. But I think also that nursing assistants in particular should, in an informal way, be assessing these behaviors pretty much every day when they're giving care, so that they should be aware as they're giving care, are these behaviors occurring or not, and so that they have a kind of a baseline to know if somebody's having pain. So in that sense, if you're giving care every day, you don't necessarily need to fill the form out and record it in the chart, but you should be looking at it. Also, in acute care settings, you probably are going to do it quite a bit more often, because there are a lot more reasons for people to have pain, and it's generally a pain assessment as part of the vital sign assessment, the routine vital sign assessment. So you should be assessing pain in hospitalized patients as often as you are taking vital signs, and more often if you're giving some kind of treatment, if you're giving medication. You would certainly want to check again after you've given analgesic medication to see how effective it was. And I think no matter what score you get, if you see an increase in behaviors that are on the pain ad or new behaviors, that should always, I think, prompt a more in-depth assessment about pain, and using the pain ad and the other assessments that we've talked about. One of the biggest challenges is that sometimes it's difficult to know whether these behaviors that you're seeing are pain related or they're from something else. Some of the indicators that are on the pain ad, for example, some of the breathing difficulties and the facial expressions, like a frightened facial expression, could indicate that the person's having a lot of anxiety. And so, or it might indicate that the person's afraid, or maybe there's an infectious process going on, so you don't really know what it means. And so sometimes it can be very difficult to really know for sure whether something's the behaviors are pain related or related to something else. I think that's one of the biggest difficulties. And what we like to do for that is repeated assessments, number one, assess other things, as we've said before, looking at past painful history, looking at physical problems, current physical problems, to see if there is a reason that the person would be having pain or not. And sometimes if you can't find a reason, you might want to give an analgesic anyway and see if giving the analgesic actually helps the behaviors. If it helps the behaviors, then you can be relatively certain that the person does have a pain problem. There are a number of other resources available to nurses in trying to understand and treat pain better than we do. One of those resources is the companion article to this video on pain assessment in people with dementia and pain assessment in older adults. There are two separate articles. Another resource is the NYU Hartford Institute for Geriatric Nursing, and they have a website that has a lot of resources for nurses and other health professionals.
The prevalence of pain in older adults is relatively high. And so what we know from the research that's been done is that between 25 and 50% of older adults living in the community have some persistent pain. And between 50 and 75% of older adults in nursing homes report pain. And those studies have largely been done with patients who are cognitively intact. But there has been a lot of work as well with patients who have dementia. And I know, Lois, that you're pretty familiar with that population.
Yeah, prevalence of pain in people with dementia is actually very similar to people with normal cognitive functioning who reside in nursing homes. It's approximately 40 to 70%. That's what's been reported in the literature. And actually, this population of older adults is at probably the greatest risk of unrelieved pain because in large part, we don't have very good assessment tools, and nurses and other health professionals don't really know how to assess people with dementia for pain.
And do you think that that leads to nurses assessing less for pain?
Well, I certainly do. I think it's one of the biggest problems that we have is that these people are often, their reports of pain might go ignored, or they're not believed, or the behaviors that they might exhibit that might indicate pain, people and nurses in particular are not aware of what those behaviors might be.
And we find even with patients who are cognitively intact that older adults tend to not report their pain. And so when a patient does not report their pain, nurses have a tendency to not ask the questions or to not screen them if they're not complaining of pain.
That's right.
So,
yes, and sometimes if people are, for example, lying on their bed or they're quiet or they're asleep, we go into their room and we think that they couldn't be having pain because they're asleep or they're not saying that they have pain. So it can be a very largely ignored issue for older adults.
And, you know, we certainly want to provide a lot of education and staff education to, you know, practicing clinicians and nurses in the field. But I think one thing that absolutely has to happen is that the tools and the assessment and screening for pain has to really be embedded into policies and procedures, whether it be in nursing homes or in home care or hospice. So we have to have some real standards where nurses are asking patients every day or assessing their pain every day in the nursing home for sure. And then that also prompts the nurse to, again, if they have a patient who is either sleeping or a patient who may not be complaining or exhibiting what they think to be signs of pain, to overtly go out and ask the patient if they have pain.
Yes, I agree with that totally, Ellen. And I think another issue with older adults is that they're reluctant to report pain because they think that it might mean that they have a very serious problem that they don't want to know about, or they don't want to bother people in the health professions with their complaints of pain. They're afraid of some of the medications, and they're afraid of side effects. So there are many reasons why people with older adults don't like to report pain.
Absolutely. And what we find is that from reports from older adults, that when they do report pain to clinicians, it is often ignored. And so at times clinicians will say, well, you know, it's arthritis, or you're 85 years old and you have some pain in the morning. And so patients don't want to report it because they know that nothing is going to happen. And they do consider pain to be a normal part of aging.
Correct.
So it does take education on our part to say pain is not a normal part of the aging process. Certainly it's associated with things like osteoarthritis, which is, you know, prevalent, certainly pretty high prevalency rates of osteoarthritis in older adults that can cause pain, but it's not a normal part of aging. And also to educate clinicians that even if someone is reporting mild pain every morning from osteoarthritis, that that there needs to be a plan in place, and it needs to be discussed with that patient as to what they want to do, because patients are very reluctant to think about taking a narcotic or adding another pill to their regime when they're already taking a large number of medications.
The other thing with people with dementia is that a lot of times clinicians will get used to behaviors that people have. So they'll say, well, that's just their normal behavior. They always act like that. They're always agitated in the morning, or they're always hitting out, or they're always moaning. And that behavior gets ignored after a while because they tend to normalize it, which is a very dangerous thing to do.
Mm-hmm.
So
now, do you find that working with families as well and caregivers?
Yes, I think that families and caregivers are also, in terms of people with dementia, they're fairly unaware that some of these behaviors could mean that the person's having pain. So families need to be educated, caregivers need to be educated to, when they see one of these behaviors, that they understand that they need to follow up with something.
And I find that patients themselves are really unaware of a lot of the non-pharmacological interventions for pain. So I think as clinicians, we need to be more proactive in, you know, discussing with patients what a management plan might look like. So it's not just adding another narcotic or another pain medication, and that asking patients how they get relief, because we do know that patients with persistent pain often use interventions that they know work. So it's a matter of, again, discussing that with patients and finding out what are some of the things that we might offer that might help.
Oftentimes, older adults have had pain for such a long period of time that they tend to normalize it themselves, and they might think that nothing can be done about it. And I think with some encouragement often that they are willing to try some treatments for pain that they haven't been willing to try before. But it's an educational process with them as well. They need to learn that they don't necessarily have to live with that much pain and what impact it has on their lives. And they may not even realize it can make them more depressed. It certainly will have an impact on physical functioning. It can have an impact on social functioning, leading to social isolation, can have an impact on appetite and many other quality of life issues that if we could improve those for people, it would make their lives a lot better.
Absolutely. And, you know, we find that very often pain and depression go hand in hand. And what we do know is that when you treat one or the other, very often the patient's quality of life improves. And we sometimes will actually use antidepressant medications as adjuvant therapy to treat pain. So I think it's important as part of our screening and assessment for pain that we do consider whether or not the patient could potentially be suffering from depression, and then potentially do depression screenings as well.
Right. Yes. Yes, I think in people with dementia, that overlap between depression and pain can be even more complex than people with normal cognitive functioning, because some of the behavioral issues might be the same, and so it's very difficult to tease out, is it depression, is it pain, or is it the combination of the two, where if you treated one, the other would get better as well.
Right. But it really has to be something that is raised at the level of the interdisciplinary team, to kind of raise the whole boat and think about this from all different clinicians' perspectives. So what is the role of a recreational therapist? What is the role, certainly, of the physical therapist and the social worker? And I think when you do that, I think, the nurse tends to be that point person, to really be doing that recurrent assessment and to be documenting that and bringing that back to the team to say, I think that these interventions are working, but I think that you really do have to bring in other clinicians and help educate other clinicians as well as to the importance of this. And I think that the importance of getting nurses to use standardized tools, and that's the vehicle to communicate pain, for example, in patients, and that if you were communicating with a physician, that a nurse wouldn't just say, I think Mrs. Smith is in pain. Rather, I did this pain assessment, and Mrs. Smith is rating her pain as a 5 today, or using the pain ad. And so if you can encourage the use of certainly the try this tools and the different tools that we use to assess pain, that's really the best way to communicate across disciplines, get the best treatment plan.
I think in terms of education, it's certainly extraordinarily important to educate physicians, not only the caregivers and the nurses, but physicians need to have an understanding about the behaviors too, because in my experience, physicians often relate behaviors to the dementia, and there's like nothing we can do about it. It's just part of their dementia. Well, now we're beginning to understand that there's reasons for behaviors, and there's things that we can actually do. But physicians in particular, I think, and the interdisciplinary team, as you mentioned, also need to be on board with what's in the pain ad and why we think that those behaviors are pain related. Some of the behaviors that I think that we see not only in people with dementia, but really a lot of older adults, is declines in physical function. You might see a change in their eating patterns, where they eat a lot less than they used to, or they're reluctant to eat, or they might stay in their bed more and not want to get up, might not want to move around. Those are some of the behaviors. We also might see some resistance during caregiving, things like moaning and groaning, facial grimacing, some of the standard things that you expect to see in people that have pain, whether they're demented or not. And so anytime you see these behaviors, it should ring a bell with you that you might need to do some further assessment. In terms of people with dementia, some of the things that we can do to minimize pain has to do with how we provide care. In the studies that I have done, we have found that the way that the care is given really has an impact on how much pain people have. For example, if we try to use real gentle approaches and move people slowly, give people timely warnings that we're going to move their body or that we're going to touch them, often we find that pain is stimulated during care because the body's being moved. And a painful joint or a painful extremity, if you touch it or move it quickly or without warning, it can be very painful. So we always try to look at those care practices first to see if we can modify those and reduce some of the behaviors that we see. So that would always, in my opinion, be our first step with people with dementia, is to look at how we're providing care. Mm-hmm. It's important to think about pre-medicating for people in nursing homes as well. An important time to think about pre-medicating is early in the morning before getting people up and out of bed, because usually, if they're going to have pain, it'll often be exacerbated during morning care when people are getting out of bed, they're getting dressed, they're being turned, they're being cleaned, and so it's a time to think about pre-medicating before all of those activities, and then it can give them a better start to their day that isn't quite so painful.
I think that that's a great point, Lois, and Some of the things that we've done in long-term care is, again, trying to get standard orders written, and not having, PRN medication orders for patients who are cognitively impaired, because they're not asking for the pain medication. But if we do know that patients have osteoarthritis and that they are exhibiting some signs of pain on AM care, to get standing orders that are given, just like you said, so you're pre-medicating patients an hour before AM care. The other important factor is to pre-medicate patients for procedures, as we talked about, certainly in terms of pressure ulcer treatments. And again, really to drive home the point of patients who are cognitively impaired, because they're not going to say, stop, this hurts. They may, again, exhibit some of those behaviors, but it's extremely important, I think, to, again, have that embedded in the processes or have those orders already written on the chart. And I think what we do know is that usually a pain management plan has many interventions. So it has to be as I mentioned, an interdisciplinary approach. For example, in the nursing home, one of the things that we often employ is distraction. So the recreational therapists are really very involved and engaged with patients who have persistent pain to distract them from the pain instead of sitting and not being engaged in any activity. Clearly, they're focusing much more on their pain. Physical therapy modalities, certainly in terms of hot packs and cold packs and, massage therapy is extremely important. There have been some studies also that support the use of acupuncture, which we have found very successful in patients. So that has helped as well. And I think patients are much more willing to try non-pharmacological interventions because of the fears of addiction and the side effects of the medication, and again, just not wanting to take another pill. So I think patients look to what are some of the interventions, and very often know themselves what are some of the things that have helped them.
One of the biggest problems that we found in our research on pain in people with dementia is that nurses, caregivers, family members are extraordinarily reluctant to give, particularly narcotics, to somebody who is not at the end of life or in a hospice program. So there's a lot of education that needs to be done about what kinds of medications we can use with older adults, and to look for the side effects to try to really manage them.
There's definitely a bias. And I think for years, we preach to avoid medications that might cause delirium or dementia in patients. So clinicians shied away from using things like opioids. And then when the studies were done to show that actually opioids is a relatively safe class of drugs with older adults, it was a whole re-education process to say it's okay to use opioids, again, in low doses and, certainly with certain standards. So I think it's been tough. I think that there is a lot of bias about using and adding another medication to a patient's regime.
Which is really an important point, because sometimes what we found in our study is adding an opioid to medication regimen that was already very complex and had medications that caused sedation. When we added the opioid, it might add a little more sedation, and it was just enough more sedation that it really scared people. They didn't like it. Family members didn't like it. And so we had to back off of the opioids, when in reality, the major side effect of some of the antipsychotics is sedation. And so if people are on antipsychotics and you add the opioid, it becomes very complex. And how do you really manage this? And the use of a lot of antipsychotics actually is one of the major difficulties, I think, of treating pain in this population because of the sedation side effects.
Right. And I don't think clinicians necessarily approach the use of opioids in terms of educating patients and families to say this may have a sedating effect initially, but given time that you will feel better and you will not have those sedating effects. So you see exactly what you said. You see patients having a sedating effect, then families and or patients saying this is not where I want to be in terms of my level of orientation and I want to be awake. So, then they won't take anything. So then you swing back to having, again, another problem.
One of the things that we found is that nurses and other health professionals are really not afraid of the sedation side effects from antipsychotics, but they are for opioids. It's really kind of a strange thing when you think about it. But I think sometimes if we start opioids, if we really suspect pain and try an opioid, we can often reduce the antipsychotics or, you know, at least take a look at the medication regimen to see, is there something in here we can take out of this regimen so that the sedation isn't so great. And it's a very complex management issue, however, and a lot of the disciplines, including nurses and physicians, get real, I would say, hesitant about changing those kinds of medication regimens.
Right. And I think, you know, most of the pain that we see in older adults is you know, persistent pain secondary to osteoarthritis. That's the most of the pain that we see. That's relatively simple to treat. And when we do get into patients who have much more complex pain management issues, it's very time consuming. It takes a lot of time. It takes time to not only try different interventions, but to go back and assess. And so it's something that very often today, due to staffing issues or due to an office practice, that there's not a lot of time dedicated to that. So I think that that contributes as well to people, again, not having their pain managed very well.
There's also been quite a bit of, not quite a bit, but there's been some research on people with dementia in acute care settings and how they receive far less pain medication than cognitively intact people. And in fact, sometimes though, after a hip surgery or other surgeries, they will have little to no pain medication and little to no assessment really. And I think the dementia piece is an added layer for nurses in acute care settings, that they really don't have the skills for assessing people like that, and then what to do about the pain if they think maybe they have pain. They're afraid to give the medications. They may not give enough, and they think the person is delirious, and so they don't want to add an opioid to the medication schedule. So there are lots of issues in acute care with people with dementia as well. I think a key for nurses in acute care that they could use in terms of their decision making is to realize that most surgeries that people have are going to be painful. And often people with dementia are given no pain medications or very, very little. And so to understand that they need to have scheduled pain medications just like anybody else, and not to just withhold it because they have dementia. Very often people with dementia in particular are going to have an episode of delirium during their hospital stay. One of the things that I think many nurses and physicians and other healthcare providers don't realize is that sometimes delirium can actually be caused by unrelieved pain. So clinicians really need to learn how to assess pain and not be afraid to give medication in hospital settings, because sometimes it can take care of the delirium.
Right, and it's so complicated because what we know is that when patients show signs of delirium, we tend not to want to add another medication that could potentially exacerbate the delirium, or that we're not getting a clear picture of the patient's mentation. So how do you make a decision to potentially add a narcotic that might potentially make things worse? So it is very complex, but I do agree with you that I think that, you know, teaching nurses and other clinicians how to do these objective assessments is really the best way to dig deep and to find out. And of course, you know, interviewing family and finding out what is the real root cause for somebody's either delirium or part of why they're in the acute care setting. Do you find that nurses are not as comfortable with accepting what patients' reports of pain?
Yes, totally. And I think there's a lot of literature actually to support that. When they've asked patients who are cognitively intact to report their pain, and then they ask the nurses how much pain this person has, oftentimes the nurses come up with a far lower number than patients actually do. So it's something that nurses need to learn to get over that. And in people with dementia, it's even worse, because sometimes they're inconsistent. They might be able to use a pain scale one day and they can't respond to it the next day, or they're inconsistent in their responses, or they can't attend to it. So there's lots of complexity when you start adding the dementia. But still, I think it's important to ask people, because when they understand that you're really concerned about them, and it's obvious in your tone of voice that you want to know if they're having pain, and you give them time to answer, that they will answer you often, even the ones that people tell you are nonverbal.
Mm-hmm. One of the things that we also have embedded into our pain assessments is to ask patients what their goal is for their pain relief, which obviously is much more difficult to do in cognitively impaired patients, but because some patients, don't expect their pain to be completely relieved. And so you want to make sure you have a realistic goal for that patient's pain management plan. So asking them where they want to be is extremely important. And how much are they willing to risk maybe the side effects of adding an opioid? Or some patients will say, I'm okay with a 3 with just the Tylenol. I'm okay with a 3 if I can avoid using an opioid, or if I can avoid adding another medication. And certainly that's part of what we do, is to make the patient the very center of that, developing that plan of care.
I agree totally. And the difference for people with dementia is that often those discussions have to take place with family members. And so family members need to be educated about, how do we know this person has pain? Because it's not something they intuitively know either. And so we have to educate them about the behaviors on the pain ad that we see, and why it is that we want to medicate them, and what we think we want to accomplish, and to get their input also about the goal for the person's care and what they think the goal should be. And I think in people with dementia, that one of the ways that you can sort of institutionalize pain assessment is to train the direct caregivers in looking for behaviors during caregiving activities. So they do need to become very familiar with these behaviors, so that they can notify a nurse when they're either seeing a new behavior, or they're seeing a behavior that's escalating over the recent past few days. So the direct caregivers can participate certainly in this assessment, and need to, because they're the ones that are going to be able to actually see the person during caregiving and be able to make that assessment and then notify somebody.
Right, absolutely.
Okay, let me take this down. Okay. All right, I'm back, class. I hope that you really embraced this video. It was a long video, but it was well worth looking at, because we must do a little better job on assessing pain in our patients who are having some dementia or other problems on our elderly people. So what we're going to do is that when we come back on Thursday, we're going to just real quickly, briefly review some of the material in there, because it is definitely testable in this particular video. And then I'm going to talk about the World Health Organization, the 3 levels of pain medication that we'd like to use for our older population, and give you a few examples of that. There are some critical thinking exercises also at the back. I'd like to work with you on those. They're a little bit different from your usual types that you're familiar with, and I just want to see how you do on those. So we'll do all that and finish up. Shouldn't take too long on Thursday. And we will continue with this other information that we have on Thursday. All right, does anybody have any questions on the pain information so far? Okay, all right. Well, I've got about 7 minutes till. I'm going to be letting you go here because I don't want to start another discussion about